600,000. That's how many people suffer a first-time ischemic stroke every single year just in the US. I mean, that's a staggering number. And when that clock starts ticking, literally, brain tissue is on the line. The medical decisions made in those first few crucial hours, they can absolutely mean the difference between a full recovery, severe disability, or even death. And we're not just talking about some tiny subset of patients here. Ischemic strokes, the ones caused by a blockage cutting off blood to the brain, they actually make up the vast majority of cases, sitting right over that 80% mark. This huge population is exactly who these life-saving protocols we're unpacking today are built for. So let's get right into it. Welcome to this explainer. Today, we're breaking down the highly anticipated, brand new 2026 guidelines from the American Heart Association and the American Stroke Association. These updates, they're the absolute cutting edge of acute ischemic stroke management. They're totally replacing the old 2018 and 2019 standards with some major paradigm shifts, covering everything from the ambulance ride all the way to the operating table. Here's the roadmap for today's explainer. We'll trace the patient's survival journey chronologically, moving through the pre-hospital race, ER evaluation, the thrombolytic revolution, expanding surgical options, what not to do, and finally, the new pediatric guidelines. Let's jump in. Section 1, the pre-hospital race. In stroke management, the clock doesn't start when the patient hits the ER doors. It starts the exact second symptoms appear. Because of that, we're seeing a fascinating shift in the 911 response. The 2026 guidelines now strongly recommend using mobile stroke units, or MSUs, over conventional EMS wherever you can get them. Why? Because they allow for rapid identification and direct treatment with clot-busting drugs right there in the field. It's all about getting the absolute fastest onset to treatment times. But let's be real. What if an MSU just isn't available? Well, standard EMS destination management has undergone a massive shift too. The old rule of thumb was basically just to rush to the nearest thrombolytic-capable facility, but there's a totally new workflow now. The guidelines actually endorse bypassing closer basic stroke centers. Today, if you suspect a large vessel occlusion, EMS should transport the patient directly to the closest endovascular thrombectomy, or EVT-capable hospital. The only exception is if your local area already has a perfectly functioning, ultra-fast door-in, door-out transfer system in place. Moving right along to Section 2, Emergency ER Evaluation. Okay, so once the patient arrives at the hospital, rapid triage is a race to preserve brain tissue. That means prioritizing speed over perfect information. This guideline update is a total game changer. If an adult is eligible for IV thrombolysis within the standard 4.5-hour window, doctors should absolutely not delay that IV treatment just to wait for advanced multimodal scans, like CT or MR perfusion imaging. You basically confirm the basics, rule out a hemorrhage, and push the drug. Time is brain, right? Next up, Section 3, the thrombolytic revolution. For the longest time, Alteplase was the undisputed king of IV thrombolysis. But the 2026 guidelines have officially crowned a co-standard. Tenecteplase is now recommended as a fully equivalent option for patients presenting within that 4.5-hour window. Given the international trials proving it's just as effective, and honestly, the practical perks of administering it in a single dose, this is huge validation for hospital systems wanting to make the switch to Tenecteplase. Technology is really stretching our capabilities here too. While the standard window strictly cuts off at 4.5 hours, the guidelines now strongly support an extended window. For patients who, say, wake up with stroke symptoms or present between 4.5 and 9 hours from their last known well time, we can now use advanced automated perfusion imaging. If that scan finds a salvageable ischemic penumbra, which basically means brain tissue that's struggling but not dead yet, giving IV thrombolysis is actually considered a solid, effective path forward. But, as always in medicine, the details matter. The updated data clearly shows that patients with non-disabling minor strokes, we're talking a stroke scale score of 5 or less, they actually don't benefit from IV thrombolytics. Instead, short-term dual antiplatelet therapy, or DAPT, for 21 days is the preferred route. Also, new trials have proven that combining your clot-busting drugs with other blood thinners like argatroban offers zero added benefit and is explicitly not recommended. All right, let's jump to Section 4, Expanding Surgical Options. Endovascular thrombectomy, or EVT, is that incredible procedure where a neurointerventionalist physically goes in to yank the clot out. And the 2026 guidelines absolutely blow the doors wide open on who qualifies for this. The standard window stays at 6 hours. But evidence now supports expanding EVT to patients we used to think were ineligible, specifically those with larger ischemic cores. Even wilder, EVT is now strongly recommended for patients with blockages in the basilar artery, a supercritical vessel at the back of the brain, up to 24 hours from symptom onset, as long as they have a severe stroke scale score of 10 or higher.
Which brings us to Section 5, what not to do.
Sometimes knowing what to stop doing is just as important. There's a massive protocol reversal here on blood pressure management. Historically, the push was to intensively drop a patient's systolic blood pressure below 140 right after restoring blood flow. Well, the new evidence firmly shuts that down. If a patient just had successful flow restoration via EVT, aggressively dropping their systolic BP below 140 for the first 72 hours is now explicitly labeled as harmful. It doesn't improve outcomes, and it can literally cause real damage.
And we see the exact same principle with blood sugar. Strict intensive glucose control targeting that 80 to 130 range using IV insulin, that's out. The latest trials show it offers absolutely zero benefit for 3-month functional outcomes, and worse, it actively increases the patient's risk of severe hypoglycemia. It's a very clear mandate to step back from this hyper-aggressive post-stroke vital sign suppression.
Finally, Section 6, the brand new pediatric guidelines. Pediatric stroke is rare, which unfortunately means our standard adult EMS screening tools perform pretty poorly when trying to spot it in kids. Because of this, the diagnostic pathway has to look different. MRI and MRA are now officially the preferred emergent imaging tools for children to definitively pinpoint a large vessel occlusion. Medically speaking, the guidelines take a cautious but optimistic stance, noting that Alteplase may actually be considered safe for patients aged 28 days to 18 years, assuming they present within that critical 4.5-hour window with disabling deficits.
But the really impactful update is on the surgical front. For the very first time, these guidelines officially chart out EVT windows for children. For kids 6 years and older with potentially salvageable brain tissue, EVT can now be performed between 6 and 24 hours from onset. And remarkably, for babies as young as 28 days old up to 6 years old, EVT can actually be considered up to 24 hours from symptom onset, as long as it's performed by highly specialized neurointerventionalists with pediatric experience. It is just a massive step forward for families facing the unthinkable.
Which leaves us here. These 2026 guidelines have radically moved the goalposts, stretching out treatment windows for EVT, elevating Tenecteplase, totally reshaping ambulance routing, and bringing pediatric care right into the interventional fold. So my question to you is this. Look at your own community. With these rigorous, life-saving timelines now established as the gold standard, how quickly will your local EMS and hospital systems adapt to ensure every single patient gets the exact right care at the exact right facility at the exact right time?